proceedings now. Uh, First of all, let me welcome everyone to this seminar. This is going to be a huge milestone in the history of endocrine surgery in Pakistan because endocrine surgery has not lived as a discipline over a period of time in this part of the world. However, it has improved over the time in the last 30, 40 years. Many people have joined this discipline, and now many of the people are doing endocrine surgery in Pakistan. So we will be starting the proceedings. First of all, I will invite Professor Wajab Nazim. He is the president of Pakistan Endocrine and Thyroid Surgery Association, and he will give you some introductory remarks about Pakistan Endocrine and Thyroid Surgery Association and particularly about this webinar.
Assalamu alaikum. Welcome speakers and the participants. I am Professor Khaja Muhammad Azim, who is working here as the Chairman Department of Surgery, Shalamar Medical and Dental College, and the President of Pakistan Endocrine Thyroid Surgery Association. And I welcome you all on this seminar on the behalf of the association, and would like to thank all the speakers and the participants for joining this effort to promote the quality of learning in endocrine surgery and surgery in general. Today we have an excellent panel of experts from around the globe who would be sharing their experience, and this is a great day for all of us to learn the modern techniques and how to investigate and what should be the progressive learning curve in the diagnosis and as well as the surgical techniques in endocrine surgery. Thank you very much.
Hello, can you hear me? So now Principal Shalamar Medical and Dental College, Professor Zahid Bashir would be joining us, and he will be sharing his comments about this particular webinar.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everyone. I'd like to welcome you all to this webinar on endocrine surgery being held by the Department of Surgery, Shalamar Medical and Dental College. We have with us some of the best endocrine physicians and endocrine surgeons from all around the world. We have with us Mr. Irfan Saeed, Mr. Dr. Zishan Razak, and Dr. Wais Masood, and of course our own Dr. Talib Wasim. And they'll be talking about quality improvement in surgical services, intraoperative localization of parathyroid glands, managing hyperthyroidism when to go for surgery, and Dr. Talib will be talking about preoperative difficulty index for thyroidectomy application, introduction of this application. This will be a very useful webinar, I hope, and I hope you will all learn from this. COVID-19 has, whereas it has had its downside, and it's played a havoc with the economy and with the social structure of the entire world. One positive thing that has come out is the ability to come together through internet and through online resources, and people sitting at their homes in the comfort of their places can now share knowledge and share expertise with everybody around the globe. So this is one of the programs where people from all around the world have come together and will be sharing their knowledge. And I'd like to welcome you all to this seminar, and I hope you all enjoy this, and I'm sure this will be a very learning experience. Thank you.
I would request Dr. Zishan, who is waiting for us, and it's very early in the morning over there. I hope would have been very difficult for him to share Anyway, I invite Dr. Zishan Razak. He is a consultant endocrine surgeon in University College Cork and hospital, and he has lots of experience in endocrine as well as breast sarcoma and melanoma management. So I would request him to continue with his talk, and then we will move on to you after that. Okay?
Great, thank you so
Zishan,
much.
to you, please.
Assalamu alaikum, everyone. Dr. Talat, can you hear me and can you see my slides?
Yes, 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 yes. I can see your slides and I can hear you properly.
Okay, thank you so much, Dr. Talat Wasim, for inviting me for this talk as this prestigious forum of PETSA, Pakistan Endocrine and Thyroid Surgery Association. First of all, congratulations on the formation of PETSA, and thank you to Professor Khwaja Azim and Professor Tariq Bashir as well for the kind invitation. So I know I've got 20 minutes for this presentation, so I'll be quick. When Dr. Talat Wasim invited me for this talk, I had two challenges. The first challenge was waking up at 3 o'clock in the morning for a talk at 4 o'clock. It's no problem because I normally wake up early. But the biggest challenge was how to get this talk through in 20 minutes. Localization of parathyroid gland 2020, modern adjuncts, is at least 1 to 2 hours topic. But anyways, I'll try my best. If there are any questions I cannot answer, or if there are any links you want me to send to you, you can email me. My email address is there and my Twitter is there. You can ask me for the references or anything I can't explain in these 20 minutes. I'll be very happy to go back. So in this presentation, I'll be going through primary hyperparathyroidism. Hopefully there'll be a few medical students and junior residents listening to me. So I'll be giving them a brief introduction of primary hyperparathyroidism, how it is diagnosed, what are the pre-operative imaging localization adjuncts, what are the intraoperative adjuncts. I'll share our data of the intraoperative localization techniques and the modern adjuncts that we presented nationally only last week. I'm going to talk about how to preserve parathyroids during thyroid surgery, and we'll be happy to share some of our data from our hospital. And finally, I'll be sharing the future of parathyroid localization, which is a recent evidence from 2020. So like Dr. Talat said, my interest is basically in endocrine surgery, but we also do a lot of surgical oncology in our unit, basically breast surgery, breast cancer surgery, both benign and malignant, sarcoma surgery, melanoma surgery, general surgery, and emergency surgery. There are no disclosures, and this is the beautiful city of Cork in southwest of Ireland, where I'm talking from. And Dr. Talat Wasim was here a few years ago, and we met there, I think, in 2011, and hopefully we'll meet soon in another part of the world. So very quickly about myself, I did my matric and FSc from Islamabad College for Boys, G63 Islamabad, back in 2001. I'm a gold medalist graduate from Ayub Medical College, Ahmedabad, 2002-2007. I did my house job in FCPS training at Pakistan Institute of Medical Sciences under Professor M.A. Zahid and Professor S.H. Waqar. I did my basic surgical training from University Hospital Kerry, where I did my MRCS in 2012. I did my higher surgical training under Professor Paul Redmond, consultant endocrine surgeon at Cork University Hospital, where I did my master's in surgery by research. And last year, I did my FRCS exams along with the European Board in Surgery. I'm active member of British Association of Endocrine and Thyroid Surgeons and the European Association of Endocrine Surgeons, and hopefully now also active member of PETSA. So primary hyperparathyroidism, some facts and figures. Every year in US, 100,000 new cases are diagnosed. The incidence is 1% in general population, although different studies show different rates from 0.2% to 2%. The lesson for medical students and junior doctors is it is an underdiagnosed condition. There's no screening programs in Pakistan or even in Ireland. In America, in some parts, they have screening programs like in Mayo Hospital, but not everywhere. So the lesson for you guys is, especially junior doctors and medical students, whenever you see a patient with high calcium, do a simple test, which is PTH, parathyroid hormone. If it is high, refer the patient to a general surgeon or endocrine surgeon, because they can sort out a simple problem with a simple operation. It's more commonly in the elderly people. It's more common in the females in their 60s and 70s or in their 50s. It is the most common endocrine disorder after diabetes and thyroid disease, as I said, underdiagnosed. And it is the #1 cause of hypocalcemia if you include both outpatient and inpatient settings. Now, what are the benefits of treating primary hyperparathyroidism? Like my mentor used to say, this is not a cancer. This is not going to kill people. As you know, 90% of primary hyperparathyroidism is caused by a single adenoma, while the other 3 parathyroids are normal. In 8 to 9% of cases, it is caused by 4-gland hyperplasia. Very rarely, it can be caused by a cancer, although I've never seen a cancer caused by primary hyperparathyroidism. But it's not a cancer, but it will impact the quality of life of the patient. The patients, normally females in their 50s and 60s, will have easy fractures, will have kidney stones, will have abdominal pains, will have poor memory, bipolar, dementia. So all of these will severely impact the quality of life in their late age. So it's very important to diagnose this and treat this accordingly. So what are the benefits of treating primary hyperparathyroidism with a surgery? Because that's the only option to cure primary hyperparathyroidism. In secondary and tertiary hyperparathyroidism, Senic acid has a role. Surgery is not the first line, but surgery is the first line for primary hyperparathyroidism. So the renal functions are better and the bone density starts getting improved in 6 to 9 months. You must have heard the mnemonic in your medical school: bones, stones, abdominal bones, or psychic bones. That's what primary hyperparathyroidism does to you. The neuropsychiatric symptoms are very early resolved with this, which is very important for people in their late age. It reduces suicidal thoughts and risk, which is very pertinent in the Western society. It improves your insomnia and sleep, very important concept in the late part of the life. Relieves heartburns, very important. Relieves the quality of life. Like in the West, the average expectancy of life is between 80 to 90 years. It's 82 years for a female in Ireland and 80 years for a male. So if you cure this problem in their 50s and 60s, they have a very good quality of life in the later half of their life. It prolongs survival, so has a survival benefit. Also, studies have come up recently which have shown that it reduces cardiovascular incidence, and in the long term is cost efficient because Senic acid is quite expensive. Now, in good old days, the endocrine surgeons or general surgeons used to open the neck with a big incision, look at all 4 parathyroids, used to take out 1 abnormal adenoma, and used to leave 3 parathyroids. But for the problems, big incision, longer operation, more chances of hematoma, more chances of nerve injury, longer hospital stay, poor cosmesis. Nowadays, this operation is replaced by a MIP, which stands for minimally invasive parathyroidectomy. So you have a single adenoma, like in this case, you can see a right lower parathyroid adenoma. This operation is ideal for patients who have deranged bloods, high calcium, high PTH. These patients should have a positive imaging studies, which I'll go in the rest of the slides in form of an ultrasound, system EB, or ideally a SPECT CT. A single gland is resected by a small incision, but you need your intraoperative adjuncts, the intraoperative PTH monitoring, your 20% rule with gamma probe, and frozen sections, which I'll go through the rest of the slides. Now, where you don't have facilities for MIP, or when you have MEN1 or 4-gland hyperplasia in cases of secondary and tertiary resistant hyperparathyroidism, you have to go for 4-gland exploration. Here, you can resect all glands if they're abnormal and implant half of one of them in the contralateral brachioradialis muscle. You can also use this technique for mild hyperparathyroidism. What are the advantages of MERP? Smaller incision. So suddenly your incision gets reduced from 4 inches to 1 inch. This could be very important to young and middle-aged women. Your operation time is reduced from 2 hours to 25 to 30 minutes. Less pain. It's a day case surgery. All our MURPs, they go home the same day. Very less hematomas because you're not doing a lot of dissection. No injury to recurrent laryngeal nerves because you're not seeing them. Tissue planes are undisturbed, contralateral structures are reserved in case you want to go again in that neck, and less post-op hypocalcemia. Now, this is a surgeon in UK saying in 1986, golden words, he says, in my opinion, the only localization study indicated in a patient with untreated primary hyperparathyroidism is to localize an experienced parathyroid surgeon. He was absolutely right in 1986, but now we are living in 2020. Obviously, there's no shortcut to experience. But now we have something else that Mr. Doppman did not have in 1986. We have the pre-op parathyroid imaging. So ultrasound is the first modality of choice. Please do an ultrasound on these patients because in 30% of patients, they will have a concomitant thyroid pathology. So in those patients, when you're doing a surgery for parathyroid, you can also do a synchronous surgery for a thyroid problem that can reduce 2 anesthesia down to 1. System EB scan. Localization is very important. It's a simple scan, will help you in localizing a single parathyroid adenoma, like in this case, the left lower at 2 hours. And then a SPECT CT or a 3D CT is very helpful. Now, this is American data from last year. This is a parathyroid expert who has done more than 2,000 parathyroidectomies. Now, where he's used imaging, he's able to do surgery on unilateral cases in 65% of cases. Where no imaging is done, he has to look at both sides. More importantly, there's no difference between the pulmonary nerve injury or pulmonary hypocalcemia. However, the recurrence is slightly higher when imaging is used as compared to when no imaging used. So these are the few system EB scans from my hospital, my patients. So this patient had a right upper parathyroid adenoma. System EB is glowing up beautifully. We excised adenoma in 20 minutes. Patient went home the same day. Patient got cured. This is a left lower parathyroid adenoma at the left thoracic inlet. Again, 25 minutes operation. The patient went home the same day, cured. This is a left upper adenoma. Simple enough. Now, this is a patient who had a 4-gland exploration. We found 3 hyperplastic glands. We couldn't find the 4th one. The patient came back with recurrence. You can see the abnormal adenoma was in ectopic location in the right epithalamic ligament. The system EB scan picked up. We excised it recently, I think only last week, 10th of September, and the patient was cured and went home after the implantation. But the problem is where the system EB scans are poor. This is a poor system EB scan, hence we have to go in and look at all 4 parathyroids. Sometimes system EB scans localizes an abnormal ectopic adenoma, in this case in the mediastinum in the chest. So we're working up this patient for a VATS parathyroidectomy in the near future. Radio guidance is very important. The patients come in the morning, they get this technetium injection IV, and then with the help of the gamma probe, you localize the adenoma. This is the American study which has shown that where the system EB scan is negative, radio guidance helps a lot. In terms of incision is very important. This is an incision we give in our minimally invasive parathyroidectomies, a 4-centimeter collar or coccus incision. Some people in America give lateral incisions or the specific parathyroid glands. We don't do it because if we have to convert from 1 gland to 4 gland, we can just extend the incision. Incisions are very important. This is an American presenter who had a thyroid out, and then she had to leave the American morning show because of poor cost basis. This is the wife of the ex-Brazilian president. She had a poor, you can see hypertrophic scar from a total thyroidectomy, and then she was a public presenter for years because she didn't like her scar. So scars are very important. The smaller the scar, especially in middle-aged young women, the more happy they are. Now, I'm going to share our data on intraoperative exons in minimally invasive parathyroidectomy, which we only presented last week at a national level surgical conference in Ireland. So we used the intraoperative PTH assay. The concept was given by Evan et al. In 1990. PTH has a half-life of 5 minutes. So we take the PTH before we take out the adenoma, we take out the adenoma and take out and do the PTH again in 5 to 10 minutes. If you've taken out the correct adenoma, another 3 parathyroids are normal, the PTH will drop down. So this is called the intraoperative PTH assay, which was given by Irvin et al. The problem is the intraoperative PTH has a sensitivity of 80 to 95%, not 100%, hence in 16% of patients is a failure rate. Then comes the concept of Norman's 20% rule. So we take out the adenoma and we take a count on the background, and then we take a count on the adenoma. If the adenoma count is 20% of the background, it means it's the correct adenoma, and we are happy that Norman's 20% rule is positive. But the problem is, again, the sensitivity is not very high. This is a study from our unit which showed that in cases of an abnormal adenoma, the 20% rule was positive in like more than 48%. But when you take out other things which are not parathyroids, the 20% rule is negative. So the aim of our study was to evaluate the validity of intraoperative PTH assay, 20% rule with gamma probe, and all our parathyroids that go for frozen section. So over the last 2 years, May 2018 to April 2020, we included all the patients with primary hyperparathyroidism, and we excluded the patients who needed 4-gland exploration, like secondary, tertiary, or MEN1 patients. So this is a small incision. All patients have system EB scan and SPECT CT on the morning of surgery. Small incision, parathyroid adenoma is localized and excised. We do the 20% rule. We do the intraoperative PTH assay. We send the parathyroid to frozen section. We have a technician in the theater who gives us the parathyroid results in 5 minutes, which is very quick using this machine. And eventually, the final success is based upon the final results of normal calcium and PTH at 6 weeks follow-up. So we had 45 patients, 35 females, 10 males, at mean age 62 with a range between 30 and 79. The final histopathology showed that in 43 patients out of 45, we took out the correct adenoma, where the 20% rule was positive in all those 43 patients. However, 2 patients had abnormal thyroid tissue, had thyroid tissue excised instead of parathyroid tissue. So the 20% rule was positive in all 45 patients, given it a sensitivity and specificity of 100%. However, the PTH only dropped in 41 out of 45, but did not drop in 4 cases. Out of those 4 cases, 2 were parathyroids, 2 were thyroids. Hence, the PTH has a sensitivity of 95 and a specificity of 100. Sorry, I have to rush through this data because of shortage of time. But the frozen section was 100% sensitive and specific. So where there was parathyroid taken out in 43 cases, it showed parathyroid tissue, and where there was thyroid tissue taken out in 2 cases, it showed thyroid tissue. Eventually, we made the conclusion that when radio guidance with 20% rule and frozen sections were added to intraoperative PTH assay, the success rate goes up to 100%. And so we recommended that these 3 agents should be used together to reduce the risk of recurrent hyperparathyroidism to a minimum. Now, last few slides, what are the latest innovations in localization of parathyroids? So this is the parathyroid eye. I saw it in New York in the Mount Sinai Endocrine Masterclass in December 2019 before COVID hit in. It's a simple fiber optic probe with a laser. You put the probe in, it is worked with a foot paddle, and the probe will beep, and this graph will go high when you're near to a parathyroidenoma. So this will help you not only in your parathyroid surgery, but also in your total thyroidectomy, where an endocrine surgeon wants to preserve the parathyroids to reduce the risk of transient and, more importantly, permanent hypercalcemia. Autofluorescence is not a new thing. This paper is from 2014, so obviously this was in place for the last 5-6 years. Colorectal surgeons use it for their bowel resections. HPB surgeons use it for their difficult lab colis, and endocrine surgeons use it for localization of parathyroids. You can see here it's difficult to visualize this parathyroid in a thyroid specimen, but when autofluorescence is turned on, it beautifully lights up, and you can save this parathyroid, and happy days. So what are the use of autofluorescence? Identification of parathyroid tissue intraoperatively in real time, very quick. Localizes the parathyroid gland prior to and after dissection. So once you've taken it out, you can turn on the autofluorescence again. If the light is gone, happy days. It distinguishes healthy from diseased parathyroid glands. It's important not to remove normal parathyroids, as I'll explain later on. And more importantly, especially in the cases of total thyroidectomies done for benign and malignant cases, it reduces post-op hypocalcemia, both transient and permanent, because you're leaving normal parathyroids behind. But everything has limitations. Autofluorescence is not 100%. It can be false positive in colloid nodules, in brown fat. It can be false negative when your adenoma is intrathyroidal, or if you have secondary hyperparathyroidism. Overall, I think it's a great technology and should be used. Now, this might be relevant to a lot of endocrine surgeons, especially in Pakistan. How do you intraoperatively localize parathyroid glands during a difficult thyroid surgery, like a multinodular goiter, a big one with uterine extension, or a thyroid cancer? So my answer to that is, do you know your inadvertent parathyroidectomy rate? Inadvertent parathyroidectomy is when you take out normal parathyroids during a course of taking out a thyroid. Most of the endocrine surgeons, unfortunately, do not know their inadvertent parathyroidectomy rate. Hence, we did an audit from 2012 to 2014. We do about more than 100 thyroids in our hospitals. We have a high volume endocrine center in the context of Ireland and Europe. And our parathyroidectomy rate 2012 to 2014 was 17.3%. We did a re-audit from 2016 to 2019, and our negative or inadvertent parathyroidectomy rate dropped to 14.8%. So there was a 2.5% drop on closure of this audit loop. But we didn't do anything fancy. We only did 2 small things. First of all, we paid visual attention to parathyroids intraoperatively. I recommend that all endocrine surgeons should use loops, as it will help them in direct visualization. But the eyes cannot see what the mind doesn't know. If you don't look for parathyroids, you won't find them. Other thing we did was actually Hawthorne effect. Hawthorne effect says that if you're observing somebody, their performance will go up. So we made compulsory that any person who does a thyroid surgery, they look at their own pathology report. And if they find parathyroid tissue on that thyroid gland, they should give a feedback to the consultant what was the cause. In this way, we reduced our inadvertent parathyroidectomy rate by 2.5%. Hopefully, we'll bring it down to a single figure soon. We presented this data in the Association of Surgeons of Great Britain and Ireland, which is the largest surgical meeting in the UK. And this paper won the Best Research Paper Award, which was great. Last few slides, because I have 1 more minute to go. What are the latest innovations in future? Goggles. So the goggles will come in the next year or so. in which you'll be able to see the parathyroid with your own eyes and you can preserve them. And people are talking about detecting vascularity with the help of laser spectral contrast imaging as well. But the bottom line, a fool with a tool is still a fool. If you can't use the tool, you're still a fool. There's no shortcut to experience. Last few slides. David Scott Coombs is a retired endocrine surgeon from Cardiff, UK, after 35 years of endocrine surgery. I went last year to him in London in the Hammersmith Symposium in Imperial College of London, and he told me 3 points. Even the best endocrine surgeon will sometimes fail. So failure and recurrence is not, don't take it to the heart. It will happen to best of us. So just learn from it and move forward. Do no harm to the patient. These patients have benign parathyroid problems. Do not remove normal parathyroids, otherwise they'll be hypoglycemic for life. More importantly, do not injure the recurrent injured nerves. Because if you do, they come with a benign problem and they go back hoarse, which is a disaster. Last but not the least, relevance of anatomy and embryology is very important. You should look for abnormal ectopic parathyroids, like in the mediastinum, like in the thyrothymic ligament, like in the carotid sheath, like in the retrosacral space, if you can't find them in normal places. So I think these are nice lessons. At the end of the day, patients are our basic feedback mechanism. This lady was very happy with the surgery done by American parathyroid surgeon for her recurrent primary hyperparathyroidism. Hence, if patients are happy, it gives us satisfaction at the end of the day. I leave you all with my take on surgical innovation, which is given by Atul Gawande, a famous American endocrine surgeon and a writer. If you have willingness to try, you will bring surgical innovation. Thank you so much. I leave you by saying go rap met agat, which is Irish for thank you so much. If you have any questions, you can email me or tweet me and I'll be happy to answer. Thank you.
Okay, that's a wonderful talk, Dr. Zishan, and we would have a couple of questions after all of the other presentations are done. Would you like to bear with us, or you would like to continue?
No, obviously I have to go to hospital in 2 hours, so I'll be happily staying.
Okay, that's great. All right, the next talk will be by Dr. Irfan Saeed. We have been fortunate that we have uploaded his link on the YouTube, and it will be running now. This is the talk that he will be taking through the YouTube, and after that he will be available for the question answer session. So I will go ahead and move to that. Just bear with me for a moment.
I want to thank Dr. Talib Wasim and other organizers for giving me the opportunity to speak about quality improvement programs in surgery with a special focus on American College of Surgeons NSQIP program. I have no financial disclosure. Goals for today's talk are going over history of American College of Surgeons specific to quality. What is NSQIP program? How this program is different from other quality programs? How does NSQIP help participating hospitals and other quality programs which are related or directly or indirectly to NSQIP? If you look at the history of American College of Surgeons, you can see they have a rich quality history over the course of almost 100 years now. As you can see from timeline that American College of Surgeons have developed and successfully implemented multiple initiatives, and as you can see, it's starting from issues of minimum standards for hospitals, to Cancer Commission, to Trauma Committee, Joint Commission, and accreditation of different subspecialties. For example, surgeons on oncology group, bariatric surgery, breast centers, and development of NSQIP. What is NSQIP program? The history of NSQIP program starts in 1990s when Veterans Hospital launched a quality program to improve surgical care for veterans. This program got national attention, and later American College of Surgeons launched ACS NSQIP in 2004. This program is a nationally validated, risk-adjusted, outcomes-based approach to measure and improve the quality of surgical care. NSQIP employs a prospective, peer-controlled, validated database to quantify 30-day risk-adjusted postoperative surgical outcomes, which provide a valid comparison of outcomes among all participating hospitals. If you look at this graph, almost 719 hospitals across the world are participating in this program. Mean bulk of those hospitals are in the United States, 585, with almost 96 hospitals in Canada. And this program has grown exponentially at an international level with sites all across the world, from Australia all the way to England. And I'm very proud to say that Al Khan Hospital from Pakistan is also a participant of that. How ACS NSQIP is different from other quality improvement programs. Most hospital-based quality improvement efforts are based on administrative or claims data by insurance companies. Claims data does not adjust for risk factors, for example, age of the patient. A 21-year-old young healthy patient is not comparable to a 75-year-old patient with comorbidities. NSQIP data is abstracted by a trained surgical case reviewer from medical record with a 30-day follow-up post-operatively, while claims data is generated electronically at the discharge of the patient from the hospital. The guiding principles for continuous quality improvement are setting up the standards, which are individualized by the patients, and they're backed by research, developing the right infrastructure like staffing models, appropriate nursing staff for patient to nurse ratio, general surgeon to population ratio, specialist requirements for community and setting up their high standards, equipment validation, processes and implementation, and implementing checklists for safety, like timeout before surgery and debrief after surgery. Maintaining that rigorous data is extremely important. Collection and validation from medical charts. The data should be backed by research, and also feed for more research. Post-discharge tracking system for patients, as it has been proven that a lot of complications happen when the patient is discharged from the hospital at home, and continuously updating your data. The last part is verification, which should be external peer review, and it creates public assurance about the program. How does NSQIP help participating hospitals to implement these improvements? American College of Surgeons offer hospitals and clinicians necessary tools, periodic reports, statistical analysis, and support to collect data and implement quality improvement initiatives. Benchmarking, for example, hospital-specific reports and compare them to the state level and the national level. Provide periodic reports, which are called semi-annual reports, and collaborative meetings to discuss those findings and try to improve patient safety. Access to best practice tools backed by research, and reporting software which can communicate with modern electronic medical records, and site audits in order to make sure the data is valid. If you go to American College of Surgeons website and click Quality Program Overview, these are the list of programs which are already in place. You can see the American College of Surgeons NSQIP program, and there are multiple other programs which are associated with it. For example, pediatric component of NSQIP, bariatric surgery component of NSQIP, trauma component of NSQIP, and American College of Surgeons Quality Verification Program. Most recently, American College of Surgeons have implemented enhanced recovery pathway programs to minimize the use of opioids among patients, which is called ISCR program. American College of Surgeons holds on a yearly basis a dedicated quality and safety conference. Due to COVID-19 this year, this conference was held virtually, but it provides an open platform for healthcare providers to talk about quality and patient safety issues. I want to share this slide. These are the 6 lessons learned up till now, which are published by American College of Surgeons. Number 1, quality improvement is the future of medicine. We have to embark on this pathway in order to make sure that we are at the front. Number 2, quality is measurable. You have to set the metrics right. Number 3, high quality data is essential for quality improvement. Validity of that data is extremely important because you cannot make or find a solution about a problem if you don't know the problem. Number 4, quality thrives in a supportive culture. To me, quality is a team sport and will need buy-in from all stakeholders. Collaboration among individuals, hospitals, and at state and national level will drive innovation and higher quality standards. And at the last, surgeons must lead the quality initiatives. As natural leaders, it is imperative for us to take charge of our patients' needs. I wanted to share this video with you guys. Thank you very much, and I'm more than happy to take any questions. Thank you very much once again.
So thank you very much, Dr. Irfan Saeed. This was a wonderful presentation. We will be having a few questions about this particular presentation now. What is this red book? Can you hear me?
Yes, Talib bhai, Red Book is a roadmap for quality, which has been developed by quality leaders at the American College of Surgeons. Dr. Clifford Coe, I mean, he's the lead author of one of that book, and it encompasses, a lot of the challenges, which we deal with the quality in the current, time frame, and talk about how to manage them. It also guides the hospitals and organizations to find a pathway, to do that. American College of Surgeons have gone a step forward now from the Red Book, and what they have done is that they have ACS verification programs in which the leaders from quality teams will come to your organization or hospital. They will go through the processes, for a couple of days, and then they will give you a detailed report that what should be done in order to enhance quality at your hospital. I looked at that, and currently the Red Book is only available in a paper form. I called the American College of Surgeons office today, and they mentioned that most likely coming soon they will have an electronic version, but I will probably send you one as quickly as I get one in my hand. I've already ordered one for you.
Okay, that will be great. I will be banking on you for that. What are the important things or recommendations for instituting this sort of program in our setup? I mean, it will be very difficult to financially. How much the financial finances involved in this whole process?
Right. I missed a part of your question. Your question is that how much financially impact the hospitals?
Yes, yes, yes.
Okay. So the American College of Surgeons has a one-time annual fee for these, which can range from anywhere from I think $15,000 to $20,000. I am not 100% sure about it, because but I think that's the number which I've heard. If you buy multiple programs, from them, for example, my hospital has, I'm the surgeon champion for the NISQIP for Augusta University, and our hospital has got adult NISQIP, we have PEDS NISQIP, we have MBS SQIP, and so when you buy multiple programs from them, then they reduce the price. But there's some additional cost related to this thing, which is the cost for the surgical case reviewer, which is going to be abstracting the data for you. So that is an additional cost on which the hospital has to bear. I'm not 100% sure that what it will be the pricing, if, for example, outside the United States, people want to involve in the program. I don't think so that they will be charging that same level which they are going to be charging in the United States. But I can find out for you if your hospital or your organization is interested in that.
Okay, that would be great. The question is that if we have to implement on our own, I mean, without enrolling to the American College of Surgeons, our ultimate objective is improvement of the quality. So if we have to improve our quality on our own and we have to sort of install a variant of this program in our setup, so what will be your recommendations in this regard? How should we start it and how should we move on?
So the first and the foremost thing is to identify a core group of team which is going to look into that, and they have to be dedicated and persistent, because culture change is not easy. We're going to do things which is backed by research, and sometimes it is a little bit challenged because people will not do good to change. So that's number one. I mean, developing a core group of people who will look into these matters. Number two thing is that you will need a dedicated person who's going to collect the data for you. Okay. first of all, you need a foundation data in order to determine where the problems are based on your hospital. And this is extremely important, which I wanted to make a comment here. Quality or any initiative which is being done, I mean, should not be implemented that if it works in the United States, it will work in Pakistan too, or if it works in England, it's going to work in Pakistan too. Okay. Every hospital, every organization, has a different patient population. Their problems are different, and their issues are totally independent of each other. So for that reason, having the core idea but implementing on the ground is a different game. And I will highly urge that look into the issues which you have. You need a core group, you need an abstractor, and number three thing which I would say is that defining the achievable metrics first. You need small wins initially in order to gather the teams, and so the people will come on board, and then afterwards you can take on the difficult decisions. That's exactly what I did when I took over this program almost 2.5 years ago. We had a CODI-ish project, okay, which was urinary tract infections related to catheters. We had a pneumonia issue, and we had an SSI issue, which is still a problem. But we heavily invested, on those three areas. We developed protocols. We developed, involved the nursing staff, the residents, the attendings, and we all brought all stakeholders on one table. This is also very important, because if all stakeholders are on the table, then whatever you want to implement is going to work. If the stakeholders are not on the table, then it will be very difficult to implement any quality process improvement. The last but not the least, what I will say is that, as I said, in the presentation, it's a team sport. I would not recommend to single out anybody. Even though that there's a problem with with a process or with a floor, or where the patients are, inclusiveness is going to be a key here to try to bring people on board and improve quality.
Okay, that's great. Okay, if you have to start, I mean, what would be the basic? I mean, which program would you like us to start with? I mean, there are so many programs available with American College of Surgeons. What would be the easiest one to start with?
If you ask me, which the biggest impact of any program which can have is going to be starting with adult NISQIP. That is the program which has you can, if you have so for example, I give you my example of my hospital. We do at least I think 12 to 14,000 surgeries a year. That includes different subspecialties, and that does not include the outpatient surgeries. That is only the main hospital surgeries which are performed, and this also doesn't include the children's hospital. So out of those surgeries, the adult NISQIP has cycles, which are 8-day cycles. And on 8-day cycles, the abstractor will go in and have a checklist that she has to randomly pick, for example, 4 emergency general surgery cases. She has to pick a cardiothoracic case. She has to pick an endocrine case. She has to pick 2 vascular cases, and pick all the stuff. So in that case, that will give you a broader picture of your hospital, that how your where the problems are, and then define define a metric which can be easily achievable first. For example, check on your pneumonia rate post-operatively, okay, or superficial wound infection, that what your rates are going, and then on a group in order to achieve the number which is the national standard. It's difficult to find what will be the national standard for Pakistan now, because the reliability of the data is going to be questionable. But at the same time, I think this will be a good building block to start, to set up some standard. I mean, as you're talking about thyroid surgery, this conference is related to that. I would say something for that reason, that what time frame you're looking at, or like how you wanted to improve the thyroid surgery and to prevent the complications like recurrent laryngeal nerve, and trying to define some metric around it.
Okay, that's great. How are your transplants going at the moment? How many in the COVID era are you able to do transplants, or what are your practices at the moment?
Yes. So we actually didn't slow down. I mean, like, in the initial phase, the state of Georgia in US, was hit by the second COVID wave, in August. We had the first COVID wave, in March/early April. But at that time, our hospital capacity was pretty good. The basic problem, which we encountered, when we had the second COVID wave, that we did not have ICU beds available. We were to the max capacity, and to the point, that we have to convert some of our units, which were the regular floor units, into a semi ICU situation, where we provided oxygen beds and all those things. So that was the first couple of weeks of August were the main challenge for us, because I remember I have to cancel I think 5 kidney transplants, because my chair of surgery did not approve the beds, and because those beds were reserved for the COVID people. But besides that, we did not have any issue. Living donor kidney transplants are still a question right now, and they are being done on very selective basis, because you need 2 beds, and you're bringing in a healthy donor into the hospital, for that reason. So we're slowly ramping up. Most likely, we are planning to do 4 or 5 of them in October, because before the flu season hits in November, December time, we wanted to make sure that we get those things done. We do have I do know that in my program, there were 2 patients, who acquired COVID post-transplant. One unfortunately died, and one survived and okay, and did not have any issues post-operatively.
Okay, that's great. We will. Would you like to bear with us now? We will be moving to the next speaker, Dr. Awais Masood. He is one of the renowned endocrinologists in Pakistan at the moment. He is working in Doctor's Hospital at the moment, and he was previously trained in States. I would request Dr. Awais Masood to hold the mic and enlighten us about the management options, surgical management options, when we should we jump for the surgery in case of hypothyroidism.
Sure. Thank you very much, Talat, for your kind introduction. Everybody can hear me okay?
Okay. Can you please put up your slides? Oh, that's great. So we can see your
Sure.
slides now.
So, topic today is hyperthyroidism management and role of surgery when we consider surgery as a preferable option as compared to the others. Let me do not have any disclosures. So I'll start with the question in case if you are just getting lazy in this beautiful morning to wake up a little bit. My first case is a 28-year-old woman who presented with palpitation, breathlessness. She had a family history of thyroid disease. So that's a clue for the junior staff and residents. Examination, she has fine tremors, warm peripheries, and resting tachycardia with heart rate of 120 beats per minute. So if you look at her labs, clearly she is hyperthyroid with very suppressed TSH, very elevated free T4 and free T3 levels. Her anti-TSH receptor antibody was negative, meaning obviously she is not Graves' disease. So a thyroid uptake and scan revealed no uptake. And that takes me to the differential when you are seeing this type of patient, what could be the potential causes and how would you investigate further? I will take a moment actually here to, I have seen many hypothyroid with cold nodule patient, and they would never get, and they would have a thyroid uptake and scan where it is really not indicated. And I will have many hyperthyroid patients in my practice here, especially in Pakistan, that they would have hyperthyroidism going on for years and nobody tried to evaluate what is the cause, what was there an ultrasound done or was there an uptake scan done. So for the residents and the junior staff, whenever you see a patient with hyperthyroidism, approach to differential is put them essentially into two buckets. One bucket is with the patient with who have a high uptake scan and others with the low uptake scan, because the management is totally different in these two scenarios. So these are the differential with normal or high uptake scan. You can see the top leading cause is autoimmune thyroid disease, excuse me, Graves' disease, Hashimoto's. Hashimoto's is actually an interesting entity in which we see these patients, they swing between being very hyperthyroid and then go to thyroid, and then when with the immune flare up, sometimes they are hypothyroid, and then you at the same dose of the thyroxine, they start to become hyperthyroid. So that's an interesting entity, Graves' disease, you all know. And then autonomous thyroid tissues such as toxic adenoma, multinodular goiter, TSH-mediated hyperthyroidism. These are two very interesting and rare, which I will touch on those briefly because of the constraints of time. One is TSH-producing pituitary adenoma, and the other is non-neoplastic, which basically is TSH hormone resistance. And then the last one is the beta-HCG mediated, which is human chorionic gonadotropin mediated hyperthyroidism, which includes basically hyperemesis gravidarum and gestational trophoblastic disease, where HCG is over 100,000 and it sits on the TSH receptor and mediates your hyperthyroidism. Now, the next bucket, as we talked, is hyperthyroidism with absent or near absent, no uptake on your radio uptake scan. So what are the causes? The biggest cause is thyroiditis. There are many types of thyroiditis: subacute, painless, postpartum, amiodarone, radiation, and palpation thyroiditis. I haven't seen palpation thyroiditis much, just to put on there. So exogenous thyroid hormone intake, which could be iatrogenic, which could be fictitious. Ectopic hyperthyroidism, again an interesting entity, which we include stroma ovari and metastatic follicular thyroid cancer. Now, you have a hyperthyroid patient, you have done uptake scan, you know these two buckets. Now, this particular bucket, how would you further investigate? We check ESR for our subacute painless thyroiditis type of patients. We check thyroglobulin levels. For fictitious hyperthyroidism, which will be low, and in the ectopic cases, it will be high, and we will move on to whole body scan for definitive diagnosis for those patients with ectopic hyperthyroidism. So that takes me to my next case. In case if you're just sleepy, wake up. 19-year-old man presented with atrial fibrillation. Is that usual or unusual? Yes. 70-year-old presenting with AFib, one can understand, but why this 19-year-old kid is having AFib? And if you look at free T4 is quite elevated, 30, that its reference range is 10 to 24, and non-suppressed TSH, 1.8. So there are two unusual things on this slide. This kid is 19 and he's having AFib. And the other thing is he has non-suppressed TSH. When you see elevated free T4, why TSH did not get suppressed? So what are the differential? First thing first, TSH. Recheck your TSH. So as many of us who are practicing in Pakistan, we know we send TSH to 3 different labs, we get 3 different results. And that happens in USA too, but it's not that common. And there is actually a hormonal interference as the assay itself, the saturation of the assay, antibody reacting to the assay. There are even in the US, I have seen these things happen and get a wrong TSH report. What we do as a next step there is a test called TSH checking by dialysis equilibrium method, which even in US is available only on few research labs. So common things, common, check your TSH, repeat it. I don't think we have dialysis equilibrium. But what point I wanted to make is that the other possibilities, including resistance to thyroid hormone and TSH secreting adenoma, and those are the other possibilities that you should keep in mind when working up these patients. So the resistance to thyroid hormone is very rare. There are only 200 cases. Sorry, hold on a second. There are only 200 cases that had been reported. There are genetic basis to that, and the genetic basis identify those patients. So the reason I put it out there is just because when you're seeing a patient with hyperthyroidism, just don't focus on that it is thyroid, it's going to be Graves and adenoma. If things are not fitting together, things beyond, and look at the other causes too. So TSH secreting pituitary adenoma, again, a very rare, one Sweden study picking up a number of 2.8 per million, which is very rare. And again, I don't think you're going to see these type of patients, but just to think about it and have a differential, think outside the box when you're seeing things which do not fit together. So cardiac hyperthyroidism, which is a feature of, which means atrial fibrillation recognized feature of RTH, resistant thyroid hormone and TSHoma. And how do we differentiate those? That's beyond the scope of today's talk, so I would not touch on that. Now, this is the second half of my presentation, which is basically management of hyperthyroidism, and then we'll talk about the indication of the surgery in this patient. Management, as you know, basically drugs, radioactive iodine ablation and surgery. There are 3 drugs, methimazole, which we use more commonly in USA. We have carbimazole and PTU, which mainly we use in the first trimester of the pregnancy in hyperthyroid patient. These are some interesting scenarios. Patient who is allergic to thienamides, what we do with that. You know, in my experience, I ask patient what type of allergy patient has. If it is just a skin reaction, maybe giving them Benadryl, antihistamine, giving them some steroid, and then they get used to it and they do able to tolerate. Thyroid storm is an interesting entity. We'll talk about what adjuvant treatment we use in these type of patient and the rapid preparation for surgery, what options we have. So adjunct treatments, basically iodine elixirs preoperatively. We give it for 7 to 10 days to render them euthyroid quickly and reduce gland vascularity. Steroids, yes, inhibit both, decrease the secretion and conversion from T4 to T3 forms. And then cholestyramine. Cholestyramine basically blocks your enterohepatic circulation of thyroid hormones. And that way, when it combined with methimazole, it decreases your level of T4 and T3 more effectively. It's given at quite a high dose, I think 4 grams every 6 hours in those kind of situations. So now that was the question Talat had for me, and surgical management indications that to focus on those indication when we are seeing a hyperthyroid patient. So I simplified it for our junior staff. So basically there are 6 C's. C meaning compression. If there are any massive goiter who are causing compressive symptoms, we'll touch on that. We'll review some cases about that. And then the risk for cancer, if the patient have a cold nodule along with a hyperthyroid patient, which is Graves' disease or multinodular goiter, then those are the candidates that you take care of 2 problems in one go and consider surgery as a preferable option in those patients. And the rest of those I have made up by using a C. Cornea, meaning orbitopathy, basically Graves' orbitopathy, moderate to severe disease. You do not want to subject them. One, do not want to waste time for their eye disease to keep on getting worse. And 2, give them radioiodine and exacerbate their orbitopathy. We will touch on that as well in the subsequent slides. The next fourth C is calcium. So if they have coexisting primary hyperparathyroidism, as Dr. Zishan mentioned, that you're going in for parathyroid and you need to go in for parathyroid, you need to take care of if there is any cold nodule or a suspicious pathology that you already know you need to take care, or hyperthyroidism. So then next is conception plus contraindication. So I got creative with that, making those all these C's. Pregnancy, basically conception, pregnancy, and contraindication, that a pregnant woman who is allergic to antithyroid drugs, basically self-explanatory. I do not need to waste time on that. And then the last is can't control, meaning refractory hyperthyroidism, where you have where I think your Shalamar Center gets a lot of those who have tried everything. They had been on highest doses, I have heard, when I was there last time, and they had gone failed radioactive iodine ablation and nothing had worked, and now it's in the hands of Dr. Khwaja Azim and Talat to take care of them. So that is the basically refractory hyperthyroidism to all those modalities. Now let's talk about Graves candidates for surgery. So those were the general indication. Basically, those both apply to these two big causes. One is the Graves' disease, other is toxic multinodular goiter. So those 6 C's that I just explained, now we're going to talk about individually, mainly go over Graves' disease, and the toxic multinodular goiter is basically essentially is the same. So in Graves' patient, very large goiter, over 80 grams with compressive symptoms. You have a Graves' patient who has a non-functional cold nodule, has undergone an FNSC, which has shown some suspicious results. So you, as we talked before, we should take care of both problems of hyperthyroidism and the suspicious nodule in one go, and then moderate to severe Graves' orbitopathy or ophthalmopathy. So, and these are the other 3 C's, which we already talked about, and I don't have to go over with you again. In essentially where surgery is basically the best treatment in patients who are acute, who having crisis, especially in Graves' disease with thyroid receptor antibodies, orbitopathy, and it most effectively clears all of your problems. Now, for our house staff, what is this sign which this patient is doing? So she has a very large goiter, over 80 grams. Trying to highlight the compressive symptoms, you can see the massive goiter, and the sign is Pomberton sign. When she's putting her arms up there, she's basically pushing thyroid down, occluding the great neck vessels, and that leading to facial plethora. And this sign is in her case is positive, indicating that substernal extension when she pulls her arms up, and causing compressive symptoms. So this is another image. You can see a very large thyroid and compressing trachea. That takes me to some clinical points for our house staff. So tracheal compression and dyspnea. A lot of times these patients, when they come to my clinic, we talk about you having compressive symptoms and ask about shortness of breath. If they have a massive goiter, when they lay down, the goiter compresses on the trachea, they say, yeah, we cannot lay flat and we have to lay on sides. But as the compression goes on below 8 millimeter of the tracheal size, then they start to see exertional dyspnea. So ask about exertional dyspnea as well. And then when it is less than 5 millimeter, then that is really when they start to have wheeze and stridor. That is too late. I haven't seen that here. Another imaging with tracheal compression, you see trachea coming from the right where that arrow is, and your trachea moving all the way towards the right side, compressed by the large substernal goiter. So this is another interesting case. To highlight our second, we talked about the compressive symptoms, and those are the preferable candidate best served with the surgery. Now we are talking about the risk for cancer, which is the second category. So this patient comes in with symptoms of hyperthyroidism, which exam shows 2 centimeter left level 3 cervical lymph node. So a patient who looks like a Graves' disease, that essentially this case highlights how important it is to talk to the patient, to examine them. One would look at the goiter and if they have eye signs or it's a clear-cut case of Graves' disease, I don't even need to touch it. But do keep your bedside skills with you. They will help you, like in this case, that only one lymph node led to the correct diagnosis. Otherwise, this patient could have gone the wrong route. So basically, this patient is Graves' disease. What is your next step in the Graves' disease? You do radioiodine scan, neck ultrasound, initiation of antithyroid drugs or surgical referral. Since she has an abnormal looking lymph node, and we already know patient has Graves' disease, the next step will be an ultrasound, which confirms on this bottom slide. The upper is, let me go through images quickly. The top image showing basically hypoechoic, typical autoimmune appearing gland, and the third slide is showing your increased flow, which is typical for Graves' disease, and the last is very abnormal looking large lymph node, which is 2 centimeter, and it does not have a fatty hilum, internal calcification. It's clearly very abnormal. You would not expect that from any allergies or a simple infection, which lymph nodes preserve their hilum, which this currently does not have. So based on this available data, what is your diagnosis? Is it a simple Graves' disease, thyroid lymphoma? I've seen patients with thyroid lymphoma, basically underlying HIV or other process. They are not hyperthyroid. They have rapid enlargement of thyroid mass, not this presentation. Thyroid cancer, yes, we're thinking about, but Graves' disease with concomitant thyroid cancer is looks more appropriate in this scenario. So what is your next step? You do FNSC of that particular abnormal lymph node, which reveals papillary thyroid cancer. You start them on methimazole, make them euthyroid, and then total thyroidectomy. On the finding on the total thyroidectomy shows papillary thyroid cancer involving both lobes with mixed growth pattern, including papillary and solid types, and there were several metastatic lymph nodes present bilaterally. So just to pause here and take a moment, that one lymph node on examination took you to the correct diagnosis. Otherwise, if we would have missed that, and typical treatment for Graves' disease who does not have orbitopathy would have been radioactive iodine, and which would have missed all of that. And since cancer was already metastatic lymph node, it would have led to further progression. Now, this is the histopathology. The G over there on this slide is showing the areas where there is hyperplasia, and then the arrows indicate the areas where it's papillary thyroid cancer. So mixed picture on the pathology. Now, the third indication for these patients to undergo surgery is Graves' orbitopathy. As you can see from this image worth 1,000 words, this patient has severe orbitopathy. You do not want to lose this time on this patient, as what is going on behind the eyes. So just for the junior house staff, there are TSH receptors, which is the prime antigen for all of this autoimmune process going on, triggering the antibodies which are acting on the thyroid. And behind the eye, there are fibroblasts, and they have same TSH receptor, and there is interplay between IGF-1 receptor, and these antibodies are sitting down there and causing an inflammatory cascade involving T cells, leading to retroocular fibrosis and proptosis. And then if it keeps on going on, then there is scarring, hypertrophy of muscles, and diplopia. So time is essence. You sit on these patients, keep on those drugs, and their diplopia is kind of permanent, and then they would need corrective eye surgeries. So you do not want to waste these time and get them to a good surgeon rather than wasting time. So now there are the patients who have very mild disease, you work with your ophthalmologist and they're okay. We give them pulse dose steroid, and they sometimes can tolerate a radioactive iodine ablation. Those patients are very severe disease, no question, get them to the surgeon. There are patients who are in between. I usually work with my ophthalmologist and see can we get away with the pulse dose steroids to avoid that inflammatory storm and worsening, or this will be best served by surgery. So here comes your role of multidisciplinary decision making. So you always involve and do best for your patient. So now I put in TEPEZZA over there, which is teprotumumab. It is a breakthrough. Recently, trials started back in 2017, and it got FDA approval beginning of this year. Basically, it's a monoclonal antibody given IV every 3 weeks for 24 weeks. And you see that green is the autoantibody. It is sitting on the TSH receptor and just switching off all the inflammatory cascade that we talked about, which leads to the retroocular fibrosis, fibroblast activation, and inflammatory pathway. So that is a game changer. I'm sure it is not available here. Even USA is difficult to get approved in certain scenarios. It's an expensive drug. But I put it out there just for you guys to know that in coming years, maybe 8, 10, when it will become available, it may change our indication, as it is really a breakthrough. It not only improves your current situation, reverses some of the changes that have already occurred in terms of Graves' orbitopathy. Another image showing clearly proptosis. These are the bony margins, and you can see the degree of proptosis and hypertrophy of muscles. So these are the last 3 other ones that we touched based on that coexisting primary hyperpara. You're going there for hyperpara, patient is hyperthyroid. Why not to take 2 problems in one go? Conception, cannot take medication, refractory hyperthyroidism, we talked about that as well. And then, as I said in the beginning, that we put those, the indication of surgery for Graves' disease, indication for surgery in toxic multinodular goiter. These are pretty much same, except in toxic adenoma and TMNG, we have added substernal extension of the goiter, another possible indication for the surgery, which is obvious. Again, substernal extension will have some compression symptoms and will meet criteria. These are American Thyroid Association ATA guidelines, which essentially we talked about. It's a kind of a complex card. You don't need to keep that in pocket if you have remembered just those 6. These basically, they put in radioactive iodine in the first column when it is a preferred approach, anti-thyroid drug when it is a preferred approach, and surgery when it is a preferred approach. And these are the same, similar for toxic multinodular goiter. We already talked about that. I won't bore you with this card. And thank you. I'm happy to take any question if you guys have.
Okay, thank you very much. This was an excellent talk. Now I will bring some discussion on the table so that nobody sleeps now. I have a few questions for Dr. Zishan now. Dr. Zishan, what is the best method for intraoperative localization that you have experienced? I mean, we here in this part of the world, we believe in our visual cues. We localize by eyes, and we only localize by eyes because there is not much available in this part of the world. So I would like to hear about your experience. I mean, which modalities that you find are the most appropriate and most beneficial when you are localizing intraoperative?
So we are using 4 modalities. They all have system AB scans pre-op. Actually, they are system AB and SPECT CTs in our setup. We have dedicated radiologists who can interpret these, and that results into conversion of a lot of foregrounds into minimally invasive surgery. Intraoperatively, we use 3 agents, intraoperative PTH-SA. It's the most expensive one because it's 200 euros for each patient. The 20% rule with the gamma probe is not bad. And the frozen section is not bad as well, because we have pathologists who can report frozen section in 10 to 15 minutes. which is very quick. But if I go with a single intraoperative adjunct, I would go with the frozen section because the sensitivity and specificity of that is 100%. But then you need a dedicated pathologist who would give results um, within a reasonable time frame.
So you still will go with the convention. Okay. What is your experience about the preoperative localization for hyperplasia? I mean, these are the difficult cases. The static scan has a limited value, even ultrasound has a limited value. For hyperplasia, what is your protocol to localize if possible?
It's a very good question. Thanks for asking. Actually, the preoperative localization imaging is not done as a part of diagnosis. It is done as a part of localization. I know endocrine physicians love doing system image scans and ultrasounds beforehand. We actually do ultrasound scans on diagnosis without rule any concomitant thyroid pathology. We only do system image scans on the morning of operation. The role of system image of preoperative localization in foregut hyperplasia is we had a couple of cases actually with patients, young patients with secondary and tertiary hyperparathyroidism. As you know, they require total parathyroidectomy and implant. And three of the parathyroids were actually parathyroids. The fourth one was actually a thyroid nodule, but looked like a parathyroid. So when they get the technetium as a part of pre-op system maybe scan, you can use the technetium for a 20% rule with the gamma probe on table. If you have a thyroid nodule that looks like a parathyroid, the 20% rule will be negative, and you keep searching for the float parathyroid. But if you don't have it, you can't. And then you have to go back in that neck again to take out that fourth parathyroid because the patient won't be cured. So hence we image foregut hyperplasia as well, not from the point of view of looking at the parathyroids, because ectopic parathyroids are very uncommon, especially in foregut hyperplasia. The main thing is 20% rule the gamma probe to make sure we're not missing one of the four parathyroids in the neck. Sorry, Dr. Talib, I can't hear you there. I think you might be muted, Dr. Talib. I can't hear you. I'm sorry.
Can you hear me now?
Yes, I can hear you now.
Okay, okay, okay. Do you have any experience with video assisted or trans auxiliary or any other approach, endoscopic approach for parathyroidism?
Yes, we have done transoral endoscopic thyroidectomy via vestibular approach. We did about 3 cases in our hospital, but the problem is, and these are all young women who didn't want any scars on their neck. But the problem is the selection criteria for these patients, their nodules have to be less than 3 centimeter for beginners. And as you know yourself, less than 3 centimeter thyroid nodules rarely require surgery because of compression symptoms, and cancer is the relative contraindication. I've seen BABA, the trans-axillary approach, but haven't done it yet. But we've done 3 transoral thyroidectomies by vestibular approach, and hopefully we'll become that in the near future.
Oh, that's great. We really like your talk. Now I would like to involve Dr. West. Dr. West, can you give us a little bit more idea about TEPEZA thing? I mean, how much does it cost in the United States at the moment? TEPEZA.
Sorry, TEPEZA, so I couldn't get
Yeah.
the full question. Say that again.
So, what is your experience as well as what is the current cost of TEPEZA in the United States?
So interesting question. When I left US, it was not available. I haven't personally used it. I can tell you the cost is in thousands of dollars per infusion. I can be wrong. I can take a look at it right now, but it is very expensive, and it will be a long time before it becomes available. Its pricing is actually not available. It is, these are certain drugs that the insurance company needs prior authorization, that you have to justify the reason that why you cannot use the alternative treatments, why you cannot do thyroidectomy, for example, or why you cannot do corrective eye surgery rather than committing these patients. Monoclonal antibodies there have been used a long time, mainly for cancer related treatment. but not for this Graves orbitopathy or Graves related eye disease. So it is a tough drug to get, but I think in coming years, right now it is only one pharmaceutical company, Horizon. There is certain rules by FDA that if once they have it for 3 years or 6 years, then it can become generic and become freely available. So it's something to look for in future, but we are far away from that now.
Okay, what drugs are you currently using for orbitopathy at the moment? Apart from the
Really
scale.
very good question. So we start with the selenium. Selenium has some role in these very mild cases. Really, the next step is the steroid. Those are used in when beginning phases. They are very inflamed looking, active disease. We use pulse steroid, but really the answer is that get the immunogenic focus, which is your TSH receptor, which is a lot of it is on thyroid, but there is some on the eye too, to remove that and get them to a good surgeon as soon as you can render them euthyroid.
Okay, Dr. Zishan, do you have any experience with treating the orbitopathy in case of hypothyroidism? Great.
No, there are two experienced endocrine physicians in our hospital. When Dr. Abbas was presenting it, I was actually Googling this because I haven't heard about it in our endocrine MDTs, but I'll go back and ask them to give you a feedback, but I haven't heard about these medications.
Okay, that's great. So I will be moving on. I will give you a brief presentation about one of the applications that we have developed over a period of time over the last 8 years at Shalamar Hospital. This application is primarily for pre-operatively determining the difficulty of the thyroid operation. I will share the link in the chat box. If you want to use, you can use it, and you can give us the feedback about this particular. It's a pre-audit. I will share the general outlook of this application. Hold on. So So, so this is a talk that I will be giving actually at American College of Surgeons this year. This is a pre-operatively difficulty index for thyroidectomy pre-audit. It's a novel, reliable, consent-validated, valuable tool. So this is based on certain parameters I would like to share. And before I go to the application itself, it would be important to know what are the important things, how did we develop it, and what is the validity of this rating scale. So I have no disclosures. So there are many factors which are actually influencing the difficulty of thyroidectomy. It can create disease, avascularity and probability of the gland can add to it, fibrosis due to Hashimoto's thyroiditis or any other modality. Thyromegaly, size of the gland, malignancy in local region can also add to the difficulty of the operation. So previously there was a scale which was developed by Schneider and thyroidectomy difficulty scale, but there were a few issues with this one. It was only providing the operative or post-operative assessment of the difficulty of the thyroidectomy. That was actually assessment of surgeon about the difficulty of the thyroidectomy. So we need a scale or tool which provides pre-operative assessment so that we can anticipate and prepare for it. So this also disregards many other important factors which can add to the difficulty of thyroid operation. So the aim of this study was to develop a novel pre-operative difficulty index pre-audit and assess its reliability and validity. So we did a long 7 year long study regarding this one. First, we did a literature review, and we did a focus group study to define the factors involved in the difficulty of thyroidectomy apart from extensive literature review. Qualitative methods in form of focus group was done. The focus group involved a panel of 8 experts with extensive experience in thyroid surgery participated. and various themes were analyzed for their relative contribution to difficulty in thyroidectomy, and a tool pre-audit was developed. This tool was later then employed on 513 patients undergoing thyroidectomy in our center for various reasons. Blinded surgeons filled a questionnaire post-operatively, which was named as post-audit, and both were correlated with each other, with operative times, operative blood loss, and post-operative complications. So the results were that thyrotoxicosis, retrosmal extension, local invasive malignancy, size, thyroiditis, short neck, high BMI, redo contralateral return, pre-existing palsy were identified as the major factors adding to the complexity of surgery as emerged through the qualitative data. This qualitative data has been presented in this table. I can't go into the detail of this table because it's too long and the permitted time for the presentation is short. Anyway, based on this qualitative analysis, a deep E-delphi study was done as a part of the study. And the experts actually rated the importance of these factors in terms of numbers. So this is the rating which was decided and agreed upon by 8 panel of experts. And based on this ratings, pre-audit scores and grades were defined. The grading was a more simplified version. So the score was maximum up to 28, and the abbreviated pre-audit grades range from 1 to 5 for the simplicity. The pre-audit grades are for the general users of the scale. For the experts, probably pre-audit scores are more information giving. So we did employ the scale on 513 patients. So these are the general characteristics of the patients. And these are the outcomes. These outcomes of those patients are well within the norms according to the international parameters. Then we did a analysis of the data, and the pre-audit scores and the grades had a high reliability, a 0.9. The intra-rater as well as intra-rater reliability was quite high in those cases. Then pre-audit scores and grades were correlated with blinded surgeon scoring, that is post-audit, and there was a high correlation ranging from 0.8, that is a quite good correlation coefficient. Pre-audit scores and complications were also significantly correlated positively. So pre-operative score was strongly correlated to the operative time, blood loss, and complications. And this is very significant. The values range from 0.6 to 0.8, which are quite significant. So the correlation coefficient was very significant in those particular patients. So our conclusion was that the pre-audit is a reliable tool to measure the pre-operative thyroidectomy difficulty index, and strongly correlates with the longer operative times and post-operative complications. This information can be useful for the surgeons to pre-operatively optimize and manage their team or resources and resident training in a more objective way. This calculator can be accessed through this particular web link. And now I will try to share some of those links, and we'll try to demonstrate it for all of you people. Just give me a little moment. So hopefully you should be able to see it now. So this is a pre-audit. We judge the difficulty of thyroid operation pre-operatively. If you go to this application on this web address, you can click on the click here button, and another window will appear. And in this window, you will see different options. Pre-operatively, you will have to select all those options, and once you select them, then you can grade the pre-audit score as well as the grade. And this information is quite significant, and pre-operatively, you should be able to know whether the operation will be difficult or an easy one. So, for example, if you go to primary thyrotoxicosis, retrosternal extension is going to be unlikely in this cases, so no extension. I will click. Thyroiditis, no. Carcinoma staging, no. Type, no recurrent palsy, no unilateral palsy, no extent of size of the gland will be either most likely that will be moderate sized. Extent of thyroidectomy will be either subtotal thyroidectomy or near total thyroidectomy. That will be most likely a near total thyroidectomy or total thyroidectomy if possible. And neck dissection fully extendable. These necks are short neck, no BMI. These are usually less than 35 BMI. So if you see the pre-audit score is 8 and the difficulty grade is 4. So primary thyrotoxicosis becomes difficult because of the hypervascularity, and there is increased risk of bleeding perioperatively as well as postoperatively. So these patients will have a higher degree of difficulty in healing. Similarly, you can go ahead with some other means. For example, if there is no toxicity and there is a cervicomediastinal extension, grade 2 thyroiditis, no, let's suppose that the carcinoma staging is, let's suppose this is a papillary carcinoma, and it has the focus, and it is stage 3, then carcinoma type, papillary carcinoma, then recurrent palsy. For example, there is a yes, there is a palsy on the one side, recurrent surgery, no. Palsy, yes. Size of the gland, let's suppose it's a moderate sized gland. Extent of thyroidectomy, that will be total thyroidectomy with the neck dissection, block neck dissection, limited neck extension. So the neck extension, for example, is a fully extendable. BMI is short neck, no, and BMI is 35. So in this case, the grade of the difficulty will be 5, and the pre-audit score will be 19.5. So this is very predictive in our study. We employed it on a population of 511 patients over a period of 8 years. So this is a very significant calculator that can preoperatively let us know whether it is going to be a difficult operation or an easy operation. And we would like you to employ this calculator. This may require some sort of optimization in the coming years because it has been only employed in our setup alone. It has to be employed in multiple centers. Once it is employed in multiple centers, then its validation will be stronger. So we would request all of the people who are doing thyroid surgery to employ this scale in their practice. And once they employ this in their practice, then we will be able to have a better idea about the validity of this particular scale. Now, finally concluding, if you have any questions, you can throw your questions. And after this question answer session, I will request Professor Fajar Mohammad Zain to give us some concluding remarks about parathyroid surgery as well as thyroid surgery. If you have any questions, you can throw now.
Taylor, can I ask a quick question from Dr. Abbas and one quick question from you, if that's
okay?
Yeah,
absolutely.
Thank you. Dr. Abbas, if Sinacalcid will come to the treatment of Manpara, available in Pakistan, what's your experience and what's the price?
It is available here. I've seen mainly in CKD patients, they are on it. I'm not sure, it's not very expensive, so it is fairly available and being used, and it's not that expensive.
Okay, perfect. Thank you so much. And Dr. Talat, a quick question from you. Congrats on developing this app and validating it in your 500 patients. Can I send it to my contacts and can we start using it with your permission?
Absolutely. To use it, and let us know. I mean, there can be certain flaws because this was validated only by 2 surgeons who are working here. And once all of the people, they work on it in all of the world, that will be great. I mean, it will increase its generalizability as well as its validity. So we will welcome that.
we can contribute our data to your database, and then we can write something together on that.
Absolutely. I will be presenting this data at annual conference of American College of Surgeons this year, and
Perfect.
hopefully other people will be. There is a University of Wisconsin group, a SIPL group. They actually developed previously the thyroidectomy difficulty scale. I have shared this with them, and they will be contributing and they will be sharing their perspective on this as well. So we will have some sort of healthy collaboration on this particular calculator.
Perfect. That's great. And one quick question from you. We are doing a 60 years old lady was medullary thyroid cancer on Monday. I just did her score and it's 18, which is grade 5. So what do you do with these patients? So do you take a high risk consent? Do you do a cross match on them? Do you make a big incision? Do you inform your cardiothoracic surgeons? What do you do with the high scores?
So that is a difficult scenario. I mean, medullary thyroid cancers are advanced. They don't appear advanced on the initial assessment, but they are involving many of the lymph nodes. So I would say that I will go all the measures which should be taken to be on the safer side. So I would like to involve everybody who is required. For example, if there is a lymph node involvement in the mediastinum, probably it will be wiser to have an input from a cardiothoracic surgeon in this regard. I will involve, we will do sternotomy, and we'll have to do lymphadenectomy if required. So it's better to involve. It is a multidisciplinary team action, and I believe in multidisciplinary action. And we should involve all of the team members, and it is very important to involve for the better care of the patient. And this is all about the patient care, and it is all about the quality. So I would like to say yes, I would involve everybody.
Perfect. Thank you. Thanks for your answer.
Okay, now I will invite Professor Khwaja Muhammad Zain, who is currently heading as the president of Pakistan Endocrine and Thyroid Surgeon Association. He is my mentor, my spiritual father, and he has actually guided me through all the last 10 years time, and he has been very beneficial and instrumental in my training as a thyroid surgeon or endocrine surgeon. And I would request him to give some few pearls about thyroid as well as parathyroid surgery, and his opinion about the parathyroid localization, and about the management of toxic thyroid with the surgical route. Thank you.
Thank you very much. I really enjoyed your very informative talk and the recent advances in management and localization of the parathyroid and the indication for thyroidectomy for thyrotoxicosis. The first basic principle for the head and neck surgery, especially in our countries, it should be a very special. The reason behind is that head and neck surgeon is only possible when you have been trained on head and neck surgery. The abdominal surgeons, they are a bit ruthless, they are a bit crude, and the head and neck surgeons, they are very delicate and gentle handling of the tissues. Regarding the hemostasis, I think the most important thing in head and neck surgery is full, complete, compulsive hemostasis, as you are operating on the dead body. Regarding the parathyroid surgery, you have said we have a very limited resources of localization except systemic scan and the ultrasound. Both they are very adjuvant, helpful, but they are not absolute. In old days, when we used to do the parathyroid surgery, we have got only two investigations. One is the serum calcium. There is no availability of the parathyroid, and the second thing what we do is the bone marrow. If the bone marrow is negative for secondary deposit or reticuloendothelial disorders, and the serum calcium level is raised and phosphorus is normal or low, we always go bilateral cervical exploration. It is a very tiring job at that time. We are trained on visual identification. It is a very difficult to identify, and you have to go through a learning curve. What we used to do it, we take a parathyroid, A, sample when we are doing thyroid surgery, B, taking as a lymph node, C, as a fat nodule, 4, as a thyroid nodule, 5th, as a thymus. And we label all these 5 tissues and we keep the record. A is for, we have removed for the parathyroid, B has removed for this one. Then we send to the histopathologist. And the histopathology report, then we compare with our own, what we thought it is true or wrong. It took us about 6 months to 1 year regularly doing this job on the, when we are doing the thyroid surgery. And after a year, we concluded whatever we remove it, it is the same as the histopathology shows. This is how we trained it. So visual identification of the parathyroid is, there is no substitute. The only investigation is to investigate a surgeon who is a regular operator on parathyroid. Because we don't have got any localization studies before. Bilateral exploration, and you should operate like you are operating on the dead body. Ruthless hemostasis. Every tissue should be its original color. We have been trained on visual identification. I am operating on this parathyroid surgery for last 30 years. We started doing parathyroid surgery in 1980, when there is no facility even for ultrasound. What to talk about this parathyroid assay? Not there in Lahore available. But later on, so we gained the experience. Even to now, we don't have the facilities of frozen section in Shalamar Hospital. Our results, they are more than 95%. We localize them. And second thing is bilateral cervical exploration is more important than a unilateral. Sometimes you have got 2 adenomas. The bigger adenoma is localized and the smaller adenoma is not localized. When you have to expose all 4 parathyroids, then you judge it. The bigger parathyroid, you take it out. We have seen a few cases when there is one big size parathyroid adenoma and other adenoma was smaller size, it was not picked up by SMDC scan or the ultrasound. They are adjuvant, they are helpful, they are not absolute. The only thing is that it should be done by not a general surgeon. It should be done a proper endocrine trained surgeons who must know, who's a regular operator to see the normal parathyroid glands during the thyroid surgery. That is the only way to which, because we have many cases, we have seen it, and they are referred, they are recurrent hyperparathyroidism. They are not recurrent, they are persistent hyperparathyroidism. They have been not properly removed the adenoma, and then they find out the adenoma was lying there, even in a normal anatomical position. The big problem lies with the secondary hyperparathyroidism, or you can say the hyperparathyroidism because of 4-gland hyperplasia. I still strongly believe there is no investigation is available for in our society, undergraduate developed countries. The only thing is that bilateral cervical exploration, see all the 4 parathyroids, and then you take the half parathyroid out first, try on 1 parathyroid, second parathyroid, sometimes you have a failure, sometimes you success, half should be removed first, then you remove the 3 parathyroids. 3.5 parathyroid removal is the best option for 4-gland hyperplasia, either because of the primary hyperparathyroidism or because of the secondary hyperparathyroidism, or in the case of a tertiary hyperparathyroidism after the renal transplant. For thyroid surgery, for the thyrotoxicosis indication for surgery in our society, they are very important indication. One, in Pakistan, India, Kashmir, the size of the gland is bigger. Bigger the size of the gland, poor the responded to the medical treatment. 1. Number 2, the compliance of the patient is very poor. These drugs are very expensive and they are not a good in taking the medicine regularly. And what happens? They have got a relapse and remission because of the poor compliance of the patient. Number 3, in thyrotoxicosis, what is called severe ophthalmopathy, I think the best treatment, irrespective of the size of the gland, is radical total thyroidectomy. That is, you only leave behind the parathyroids, the recurrent nerve or external nerve. Every bit of the tissue should be taken out in case of Graves' disease with severe ophthalmopathy. 50% people, they do respond to this exophthalmos and 50% not. Steroids have a relapse and remission. We used to do the 2 drugs. One was the Lifora. These are non-specific immune modulator drugs. Lifora के नाम से आती है, 10 milligram twice a day, and then we use also other one is the drug which is long-acting Mytica. So these are also mast cell stabilizers. So we use these 2 drugs, Mytica and the Lifora, non-specific tumor suppressor, for 6 months. And I was told by the ophthalmologist, he said, we use it, and there's a dramatic response on that part. But you have to take for between 6 months to 1 year. The Lifora and the Mytica, these 2 things, they might help. If you think the exophthalmos is not coming down, then the supraorbital irradiation or orbital decompression. Sometimes initially management, you can use the lateral tarsography to prevent the corneal ulceration and penophthalmitis. And after thyroid surgery, there's a remarkable difference because toxic type of exophthalmos do respond, but trophic type exophthalmos do not respond too much. But I think the surgery is the best option. No radioactive iodine, no antithyroid drugs, when the patient has got a thyrotoxicosis with severe ophthalmopathy. That's my remarks about this ophthalmopathy, or the parathyroid surgery to localize a surgeon who's a regular operator on the parathyroid glands, or the thyroid surgery. During the thyroid surgery, they should see and show all 4 parathyroids, and then he should perform total thyroidectomy. Thank you very much. Any question you'd like to ask?
Thank you very much, Professor Haji Azim, for such pearls of wisdom. It is all about the experience of the parathyroid surgery. I mean, we still believe in the visual cues. Number 1, it is all about experience. And if there is a doubt in any case, we still believe that the 4-gland exploration gives the best answer in terms of the long-term outcomes. So a 4-gland exploration is still valid, and we believe that 4-gland exploration should not die with the advancement in the minimal invasive techniques. So there is a place for hyperplasia as well as many other candidates in which there are double adenomas or some other pathologies exist. So I would be very thankful to all of the participants as well as the speakers. Dr. Zishan, you have been wonderful. Your talk was wonderful. And I know it was a very odd time for you to wake up at this moment to join us. But your talk was wonderful and it was very enlightening. And hopefully we will be collaborating in the future in the field of endocrine surgery. Secondly, I'm thankful to Dr. Abbas for sparing some time. He is very busy in online consultations these days. He is making money from states, doing some online work from here, and the COVID is working him wonders. I am thankful to Dr. Irfan Saeed. He did a great talk on national surgical quality improvement programs, and hopefully in the coming days, months, and years, these programs will prevail everywhere in some form. So the quality programs will eventually encompass all of the surgical care, and they have to be followed, and we will have to design some of the variants in our setup. That's what my thought is after attending this workshop. Third thing is that this pre-order thing, this is we would like to explore its generalizability and external validity. And for that, we will be collaborating with Zishan as well as the SIPL group in University of Wisconsin. So I am thankful to all of you, the participants as well as the speakers. You have been wonderful, and this program and this webinar has been very useful for our participants, and hopefully that has augmented their learning as well. So thank you all. And if you have anything to share, you can share within the chat, number one. We have recorded this session. This session will be subsequently be shared with you all after some editing. And once it is shared with you, you can utilize in your practice as well as you can utilize wherever you want to for spreading this sort of activity or this type of knowledge to your colleagues as well. So thank you all, and I am very delighted to say that this has been a wonderful success. We did it first time, but hopefully it worked for everybody, and the participants did have a uh, good outcome of this webinar. Okay, thank you very much for that, and
Thank you.
I will tell you goodbye at the moment. If you have any questions, you can talk. Okay, thank you very much. I appreciate everyone.
Thank you for having us.